Hello everyone. It's actually a pleasure to give this lecture, and I want to target before all our new young colleagues in the field to try to lead you not to accept evidence or dogmatic concepts, but always to revise and rethink what is true and what is established and what needs to be thought about further. So we all are interested in microarchitecture in bone diabetes, but also more broadly in the bone field, because of the evidence that bone mineral density by DEXA does not explain everything about fractures. And it's obviously very even more clear in diabetes, since, as everybody knows, particularly in diabetes type 2, and I will focus my topic on type 2, in type 2 diabetes, fractures occur at a higher rate among diabetics than non-diabetics, and they occur at an average bone density that is better than in non-diabetics. So that's the famous analysis of Anne Schwartz, and what my little red arrow points out is that the 10-year risk of fractures in diabetics is about the same as in non-diabetics, but at a t-score that is about 0.5 standard deviation higher. And so from there, we suppose that what explains this fragility in diabetics at better levels of BMD than normals is the other determinants of bone strength. And by that, of course, we mean microarchitecture, and we mean the material properties of bone. Now, this slide is just there to remind you that in a normal skeleton, and even in an osteoporotic skeleton, bone mass, which is your bone mineral density by DEXA, still explains at least 70% of bone strength and resistance to fractures. And that the microstructure, and particularly the material properties that were so interested in diabetes, in the normal situation, do not explain more than 20–30%. Of course, these proportions can vary in different bone diseases. If you think of osteogenesis imperfecta, then almost all the fragility is explained by alteration material properties. So it's possible that the contribution of microstructure alteration and material properties alteration in diabetes is more important than the contribution of bone density in terms of fracture risk. But to be very clear, that is a working hypothesis, and it remains to be demonstrated. Now, remember also that the increased risk of fractures for a given bone density in diabetics can be due to a number of other factors, not just altered bone quality, okay? Because the diabetic has an increased propensity to fall due to hypoglycemia therapy or neuropathy as a diabetic complication, and many other factors. That when they fall, they have higher loads because they are overweight, and that's also why we see more fractures of the upper limb, particularly clavicle and humerus, among diabetics than in the regular osteoporotic population. That diabetics may have decreased protective patterns when they fall because they have proprioceptive alterations and neural alteration, which makes them less reactive at the time of the fall, and probably many other non-skeletal contributors. So the first point here is that we should not make this simple equation that the differential risk of fractures between bone density in diabetics and normals only results from microarchitectural deterioration or material properties deterioration. It could be a number of other factors, and some of them have clearly been demonstrated, including the propensity to fall. Now, the first question, when one wants to establish the role of microarchitecture in bone fragility in diabetes, is to say, well, is there, first of all, evidence that microarchitecture and the study of microarchitecture improves the prediction of fractures independently of bone density in the general population? So what's the evidence for that? So, of course, that all pertains to the studies that have used HR-pQCT, and I remind you that these studies are about 15 years old now, The first studies came out from the group in Lyon here and Geneva that were the first two micro-CTs available in Europe after the one at the Mayo Clinic in 2004. So this was a seminal study by the group of Lyon that proved the contribution of microarchitecture to fracture risk independent of bone density, because here they were comparing two groups of women age 69, some with fractures of the wrist, some without, who had similar bone densities, but they found that they greatly differed in terms of trabecular microarchitecture. So bringing the evidence that alteration microarchitecture could contribute to bone fragility independent of bone density. After many years and many studies from many different groups, this has been further demonstrated in this study where 5 groups from 5 different countries with a total of 1,400 postmenopausal Caucasian women, 470 of whom had at least one fragility fracture. They had micro-CT, so you see here the baseline characteristics of these women. Interestingly enough, their average bone densities were not in the osteoporosis range, and this graph shows what was found. So each color represents a center that had recruited women for this study, and then the bar shows the spread. And so by and large, you find what you expect, which is that when you compare fractured and non-fractured, they are different for many of the microstructural characteristics. The cortical area would be lower, the trabecular area would be higher, the trabecular bone density would be lower, the trabecular thickness would be lower, the spacing between trabecular would be higher. So the typical description of an alteration in the trabecular network, and the cortical thickness would be lower among those with fractures. Now, two comments on this study. First, you see that the dots are spread out. So results from the same comparison, fracture, no fractures, in terms of how much deficit in cortical trabecular volume you have, can be very different in one center and another. And here, the various centers participating in the study had not cross-calibrated their pQCT. So it means the absolute values can be very different from one machine to another, from one center to another. The second more important comment here, and that's going to I'll spend quite some time on that, is the cortical bone density was actually not significantly different. What the changes here between fracture and non-fractures were the less of all the microstructural changes. Now remember that the cortical volumetric density is an inverse relationship to cortical porosity, and here cortical porosity was not measured. Now these studies, just the 2 of them I showed you among dozens, were retrospective cross-sectional studies, so comparing cases and controls, fractures, no fractures, and then doing a micro-CT to see differences in those parameters. This does not prove, of course, that the study of microarchitecture can better predict fractures than simple bone mineral density. But that also came by. First of all, again, a study from Lyon. So here in their Ophélie cohort, measures of microstructure at baseline was correlated with incident fractures. And again, they found that there was an increased risk of fragility fractures or major osteoporotic fractures if you had one standard deviation decrease, for example, in volumetric density or in trabecular bone volume or in trabecular number, etc. So again, this now demonstrates that if you analyze microstructure, you're going to improve prediction of fractures because all these analyses are adjusted for a number of clinical parameters for fractures, including total hip bone density. Here, though, you have cortical porosity, and cortical porosity was not by itself a predictor of incident fractures. Now, That study and our study and many other groups have done the same. So we've looked at baseline HR-pQCT and then looked at fracture incidence in prospective cohorts. And then we brought all this data together through the Framingham Consortium. And this then is the article that summarizes the data on more than 7,000 subjects, more than 700 incident fractures, again, looking at baseline microarchitecture as it can predict incident fractures, either adjusted by just some baseline parameters, adjusted by bone density in red, or adjusted fully by FRAX in blue. And that again confirms that trabecular, as much as cortical parameters, they predict incident fractures. The best predictor is the evaluation of strengths by finite element analysis based on microstructural points. But again, in this large consortium study, you see that cortical porosity was not by itself a significant determinant of incident fractures, whether or not adjusted by BMD or FRAX. So although we interested in diabetes and bone, we're going to put a lot of focus on porosity. What I'm showing to you here is that as an overall principle, proof that cortical porosity, at least as analyzed by the SCONCO HR-pQCT, even by itself, is not a proven determinant of bone fragility. But, that very much depends on the way you analyze cortical porosity. So this is one of the cohorts of this consortium. It's the Geneva retiree cohort that Emmanuel Biver is leading in our group. And so this shows you the same as before. It's the prediction of incident fracture by baseline micro-CT. Okay, and again, in this individual study, if you have a 1 standard deviation decrease in trabecular bone density or in cortical area, you're going to increase by 70% your fracture risk. Even fully adjusted by FRAX and BMD, you still predict 40% increase in fracture by your micro-CT. Okay, and the best predictor again is failure load. Here though, the cortical porosity is a strong predictor of fractures, contrarily to what you've seen before. What's the difference? The difference is that this porosity has not been analyzed by the regular SCANCO algorithm, but by the STRAX algorithm that Igor Simen and colleagues have developed down in Melbourne. And this is a huge difference in the way porosity is analyzed. By the way, in our Geneva cohort, what is even more relevant than to your diabetic population is that you see that the prediction of fractures by analysis, for example, of cortical area or failure load is significant in the subgroup that does not have osteoporosis on bone density. So it's exactly the situation that you would like to reach then in a diabetic population. So what about porosity? Okay, why is it that in the Lyon study, in other studies, in our general consortium, cortical porosity was not predictive of incident fractures, whereas in the Geneva cohort, using another type of analysis, the STRAX analysis, it became very predictive of incident fractures? What's the difference between porosity and porosity based on this HR-pQCT? So the way the SCONCO machine analyzes porosity has limitations. By the way it's analyzed, I'm not going to go into the technical details, that porosity only captures giant pores, more than 5 voxels, which means around 400 microns that are not aversion canals. So all the smaller porosity is not captured by this technique. And also, it only captures intracortical pores. In other terms, a pore that has erupted into the medullary space, so it's now an open pore, is not going to be seen or analyzed as porosity by the Scanco algorithm. It's going to actually be analyzed as a void, or if there is still some bone into it, it's going to be analyzed as a trabecular structure, because now it's moved into the trabecular space. And that can create, of course, some lack of precision in the analysis of cortical porosity on one side and trabecular bone volume on the other. So the other technique, the STRAX technique, it first of all captures and identifies pores of a much smaller size, probably down to 100 microns or even less. And then it has the ability not only to measure the cortical porosity in the cortex and identified as such, but also to somehow recapitulate the porosity in the inner cortex, even when the cortex has disappeared and looks like a trabecular structure. Some of these holes will be ascribed to the previously existing cortex. And that translates in huge differences in the percentage of porosity that comes out from these two techniques. And I show you this in our Geneva cohort. This is the porosity at the radius found by Scanco in our patients without fractures or with fractures, 2.6, 2.9%. This is the porosity that is calculated by the STRAX algorithm. It's in the range of 50%. And so interestingly, whereas the Scanco may lack sensitivity and does not find a significant difference between fractures and no fractures, the STRAX technique is much more sensitive because it analyzes a much larger pore volumes, and then it results in a difference between fractured and non-fractured. To the point that when you want to predict incident fractures by porosity, the Scanco porosity does not. That's the AUC under the curve for incident fractures, but the STRAX porosity does and adds to the prediction of other microstructural parameters. So my second point was to say, if you want to analyze porosity as a determinant of bone fragility in general and in diabetes in particular, you need to be careful which tools you use to quantify that cortical porosity. So let's go to diabetes, right? Because the whole discussion about porosity started about 10 years ago with the observation, first of all, by Burker, that there was increased porosity in diabetic bones. So I remind you that it was a relatively small group of postmenopausal women with type 2 diabetes for more than 5 years and of mixed ethnicities. And he described this cortical porosity. Interestingly, in that same paper, he provides images and comment on this, which is that in those images where he saw the most cortical porosity, he also captured calcification images like this, which is obviously an artery. And it was not really coined at that time, because this was the very first observation in diabetic bones. But that later became much clearer that perhaps porosity is more evident or more severe in patients that have arterial calcification, which means micro and macro vascular disease in diabetes. This observation was soon confirmed, by the way, by Janina Patch and colleagues. Here it was early postmenopausal women with and without fractures, mixed ethnicities, at least 3 years of treatment with a diabetic drug. And here I point out the HbA1c was about 8%. I'll come back to that notion. And what she showed again was that there was more porosity in diabetic bones, but particularly in those who had fractures, perhaps establishing what is suggesting that this porosity in diabetics might be related to greater propensity to fractures. Now, again, the numbers were relatively small, and I would call these more like observational studies. But then a number of studies came by, and I will review 4 of them to show you similarities, differences, and controversies about microarchitecture in diabetes. So the first study from the Mayo Clinic by Farr and colleagues is an analysis of diabetics and controls, 30 and 30, from the Olmsted County up there in Minnesota. And what I want to point out first here is that, and you see that every study is concordant for that, there is no evidence of a deficit in the trabecular network in diabetics. The trabecular bone volume fraction, number, thickness is not worse than in control. Actually, some parameters are slightly better, like trabecular number here is better. Now, for cortex, there is in this study no significant differences really, besides a thicker cortex. So more trabeculae, thicker cortex, so better bones in these type 2 diabetic patients, okay? Porosity by the Skonko, there is a little trend that you see to be higher in diabetics, but it's not significant, also pertaining perhaps to relatively low number of patients. So that first study did not confirm the concept of cortical bone porosity in diabetes, and rather showed a trabecular structure and cortical structure, if anything, slightly better among diabetics than not. Second study from Cyrus Cooper group and colleagues, 1 year later, the Hertfordshire cohort study. That was picking diabetics and non-diabetics from this cohort study. It was not designated for that. But anyway, they compared 14 diabetic men, and there were also 11 women, not shown here, versus non-diabetics. Okay, and again, what they see is that there is no alteration in trabecular structure. If anything, you see a trabecular number is better in diabetics. If anything, trabecular separation is less, and cortical density here is now somewhat lower, pertaining to an increase in cortical porosity. Not a huge difference, 4%, 5%, but it's significant. So that points now to, again, no alteration in trabecular structures, but potentially a small difference with increased cortical porosity. The third study, the Gothenburg study by Nielsen, Lawrenson, and colleagues. So again, those guys confirmed that all the trabecular parameters are, if anything, better in type 2 diabetics than in controls. They also found better cortical bone volume. And when you say better cortical bone volume, well, it does not mean increased porosity. It means, if anything, similar or lower porosity. And in fact, in their study, cortical porosity was not different between controls and diabetics. And what came out of the study here, but also from the study by far before, of course, is that there was a significant decrease in the material strength with the micro indentation, but that is not the purpose of my presentation. So as you see so far, the evidence for microarchitectural alterations in diabetes are small. If they are somewhere, they are more in the cortex, and perhaps there is increased porosity, but not always. And if it is not to a very large extent. And finally, the more recent and larger study from the Framingham group, Samuelson, first author, and Boxstein, last author. Now we have to deal with a larger number of diabetics than before, 129, and a very large control group. And here you have a little more significant differences, and they found an increase in cortical porosity that was significant. But again, the difference in porosity is about 1%. It's not a huge difference in porosity. And the other parameters, nothing was really different, besides the fact that once again, the trabecular network trends towards a better trabecular volume, thickness, and number rather than a worse one. And the result of that is that the calculated strength of diabetic bones by the fatal load, which I remind you is the strongest predictor of incident fractures in non-diabetics, the fatal load is somewhat decreased but not significantly so, despite the very large number of subjects. Now, I wanted to point out these 4 studies. There are a few more, but to me, these are the 4 most important ones that have analyzed microstructure and diabetes. I want to point out 4 studies because when you look at these data, which are not very consistent with regard to cortical alterations and bone fragility, the first thing that comes to your mind is to say, well, but what kind of diabetes those are? Because we have learned from a number of epidemiological studies that the propensity to fractures in type 2 diabetes depends on the number of diabetes-related factors: duration of disease, need for insulin, microvascular complications, level HbA1c, name it. So I went back to these 4 papers and I made a table for you. Sorry, I'll come back to that. I've made a table for you that recapitulates the main clinical characteristics of these patients. So you have the number of subjects on the top. You have the age. So first of all, you see that the age average goes from 65 to 77. So some are older than others. You see that diabetes duration goes from 7 years to 17, and the Herefordshire study is not known. HbA1c is rarely known, 2 studies out of 4, and when it's there, it's 6.6 and 7.7. So perhaps potentially on average here, a better diabetes control than there. In the Goldberg study, we know that 25% of those that were newly diagnosed, which means they have no duration of disease at all, okay? And also the insulin use. In Framingham, it's 6%. In Olmsted, it's 53%. So those guys here should be, from that point of view, duration of disease, level of HbA1c, and insulin use, a much more at-risk population, at least for fractures, than these ones here, okay? Now, we only see 10% of fractures here and 42% there. Who can explain that to me? So where would you expect a coherence in the results if every single study has looked at diabetics populations that are cross-sectional and so different in their duration of disease and other risk factors? That's very, very difficult to assess. And therefore, I'd like to remind you that as we speak of type 2 diabetes, type 2 diabetes is a continuum of a disease, right? And the classical sequence starts with obesity, then evolves to insulin resistance and a metabolic syndrome, eventually ends up in type 2 diabetes, initially controlled by lifestyle measures, then or anti-diabetics, and sometimes ending up with the use of insulin, and for less well controlled, ended up in complicated type 2 diabetes, microvascular complications, macrovascular, neuropathic, etc. As we look at those microstructure studies, they've cut across the diabetic population, not really letting us know if we are on this side or that side, certainly spanning here the spectrum across different studies and within studies, but without clear subgroup analysis. And what we forget is that before the microarchitecture analyzed here looks the way it looks, it was already impacted by what happened before. And so what we see here can be the result of diabetes, but it can also be in large part the ghost of what happened before. And to prove that, I'll show you a study about microarchitecture in obesity, again from the group of Lyon. And when you look here at this analysis of obese versus normal weight post-menopausal women by micro-CT, you'll see that obesity leads to changes in a very large number of parameters, including an increase in trabecular and cortical parameters. So in a sense, even before a diabetic becomes diabetic, he has changed his microarchitecture in a more favorable way. And then over, even if it leads to degradation of these structures, by cross-sectional analysis, what they had before can still be the predominant pattern that you see. And then you struggle to see if, for example, diabetes has a negative effect on trabecular structure, like some animal studies might suggest. You struggle to see that in a cross-sectional study in diabetes because you have the carry-on effect of the trabecular alterations, cortical alterations that you've had in obesity. And here you see there is no difference in cortical porosity between obese and not obese. So perhaps indeed the development of cortical porosity will start from a background that is not altered by obesity. Now, if you move at the other end of the spectrum that I was presenting here towards the more complicated diabetes with microvascular complications, that is where perhaps we see the most important alterations in cortical structure, as suggested, of course, by the study of Shambogi and colleagues, where he compared diabetics and controls without microvascular disease, and then diabetics and controls with microvascular disease. He found that the worst alterations of cortical bone volume and cortical porosity were in diabetic patients with microvascular disease, whereas in patients without microvascular disease, there were no significant differences in cortical porosity. But even in this worst case scenario again, you see that we have a 1% difference in cortical porosity between diabetics with microvascular disease and controls with microvascular disease. We have a 2% difference between diabetics with microvascular disease and diabetics without microvascular disease. And you see that the numbers, absolute numbers of cortical porosity are small because analyzed by the Scanco technique. And so you need to ask yourself the question, even when I am at the end of the spectrum of the disease, where eventually microvascular disease may have impacted on this cortical porosity and it becomes obvious, what does a 1% or 2% difference in cortical porosity represent in terms of fracture risk? And the studies that I showed you in the beginning in the non-diabetic population suggest that this is not a predictor of bone fragility. So not only we have a difficulty in finding differences between diabetics and non-diabetics, but even the ones we find when we analyze more homogeneous population of diabetics with advanced disease, even in that case, those differences are not proven to impact on bone fragility at that level. And the final difficulty is for all of you who do research in the biology of the skeletal alterations diabetes. Because if we start from the principle that there is indeed an increase in cortical porosity in diabetics, then the question is, what is the mechanism? Because as far as I know, the increase in cortical porosity of the aging woman with osteoporosis comes from an increase in intracortical remodeling and a negative balance in cortical remodeling. But in type 2 diabetes, I don't know that we have increased bone remodeling. Actually, what I know is that we have a decreased bone turnover. And I remind you, these biopsy studies in type 2 diabetes, 18 patients, 5 of whom had fractures, mean age 58, mean duration of type 2 diabetes 9 years, HbA1c 8.4%, so bad and poorly controlled diabetes. Okay. Now compared to the controls, all the parameters of bone remodeling, cancellous bone, endocortical bone, and intracortical bone were massively decreased. So how do you get to an increased cortical porosity if your intracortical remodeling is virtually suppressed? That's a question I leave to all of you who do biology on these bones. So that's my conclusions. And again, I don't want to draw dogmas here, but ask questions. Bone microstructure, including porosity, explains bone fragility independent of BMD in diabetes. That is our starting point, how hypothesis to do our studies and analysis. But don't be so sure. First of all, altered cortical microstructure is present in some studies, and I say cortical because, as you've seen, it's never trabecular. This altered cortical microstructure may be associated with fractures. I say that because some of the early studies, like the one by Janina Patch, found more cortical porosity in fractured diabetics than in non-fractured, but it's a handful of cases. So I'm not sure of that. It's probably worse in microvascular disease or not, because again, it's Chamboge, it's a very small number of observational subgroup and 1% difference. Okay, so this is still not demonstrated on a large scale and absolutely not demonstrated prospectively. The second thing is that all studies looking at cortical porosity in diabetes have used an insensitive algorithm, the SCANCO rather than the STRAX, and we absolutely need to move forward and use more sensitive techniques to analyze the true cortical porosity if we want to make sure whether or not it's the case in diabetes. And finally, because the relationship between diabetes and microstructure may be very different according to the stage of diabetes, glycemic control, age, etc., but not a single published study has looked into this, either cross-sectionally or prospectively during diabetes evolution. I feel that we have still no idea of how and when microstructural alterations develop in diabetes, if they develop, and we have no idea whether those alterations may eventually explain why the diabetics fracture more at a higher BMD than normals. So keep investigating it all, because so far, in my view, there is absolutely no truth established about this question. Thank you for your attention.